All right, good morning. I'm sorry for the delay. So my name is Nisha Joseph. I'm an assistant professor at Emory University, specializing in plasma cell disorders. And I'm joined today by two of my colleagues, Dr. Sara Scott, who's a clinical pharmacologist at Winship with us, specializing in plasma cell disorders, and also Roseann Pruitt, who's one of our physician's assistants, specializing in myeloma and plasma cell disorders. Thank you to those of you who are here today. It's always nice to not speak to an empty room. And thanks to the many of you who are joining us virtually online. So we're kind of representing all of malignant heme. We got one session this morning, and we're going to focus on myeloma. So we have three cases here. I'm going to present the cases. I'm going to talk through, and Dr. Scott will talk through some of the clinical trial data that's really informed treatment algorithms and how we approach these types of patients. And then we'll have a little bit of discussion and throw to Rosie and Sarah about some of the practicalities of managing these patients and these therapeutics in the clinic. So let's start with the first patient case. So, how do I see these slides better?
Do you want my printouts?
It's okay. Can I, I'm going to move to this side. So Mr. A is a 69-year-old gentleman. He's found to have an elevated total protein on routine labs with his primary care physician. He otherwise feels well, usual state of health, denies fatigue or bone pain. His past medical history is notable for hypertension and hyperlipidemia. He denies any tobacco, alcohol, or drug use. He's retired, married with adult children. His grandfather has prostate cancer, otherwise an unremarkable family history in terms of blood disorders or cancer. His medications are there. So further workup shows a normal creatinine, normal calcium. His white count, hemoglobin and platelet count are within normal range. Immunologic studies are sent because of this elevated total protein. He has an SPEP of 1.5 grams of an IgG kappa paraprotein. His free light chains show an elevated kappa of almost 600 with a ratio of 60. He has about a gram of paraprotein in his urine, which is kappa light chain restricted on IFIX, and he has an elevated IgG level of about 2,600 with a suppressed IgA and M. Further workup, a bone marrow biopsy is done, which shows a 30% clonal kappa-restricted plasma cell population. He has some trisomies on FISH, but negative for high-risk features and a normal male karyotype. And the PET scan is done, and that is negative for any signs of lytic disease. So in conclusion, this patient has what looks like smoldering myeloma. So a clonal population of cells between 10 and 60%, and no slim crab criteria, so no hypercalcemia, renal dysfunction, anemia, lytic bone disease, and overall a relatively small burden of disease. So keeping this in mind, what is the next best step in management or treatment of this patient? Would it be A, active surveillance, B, induction therapy with DARA-RVD and referral for an autologous stem cell transplant, lenalidomide and dexamethasone, or a clinical trial? So keep that in mind as we talk through some of the data. So historically, how we've thought about smoldering myeloma is an asymptomatic precursor state. And so historically, the standard of care has been observation. And the reason for this is twofold. One is the therapies that we had were thought to be too toxic, and so we're having a higher risk versus benefit in an otherwise asymptomatic population. And two is that we really had inadequate models of how to risk stratify these patients. And so keeping in mind that smoldering myeloma is a very heterogeneous group of patients, and so we were having trouble really identifying who within that group would really benefit from treatment versus those who had more of an MGUS type phenotype and wouldn't need early intervention. And this has really changed in the modern era. We have better therapies, more effective therapies, and we have better risk stratification models where we can really tease out which patients might benefit from treatment. And so this is the Mayo 2018 or 2220 criteria, where we looked back retrospectively at a large group of smoldering myeloma patients, and we were able to pick out 3 independent risk factors that predicted the progression, risk of progression to symptomatic myeloma. And that is an M spike over 2 grams, bone marrow plasma cells over 20%, and a free light chain ratio over 20. And whether the patient has 0, 1, or 2 to 3 of these features, that classifies them as low, intermediate, or high risk. And you can see here, there's quite a variation in terms of time to progression. The low risk patients up to 9 to 10 years before progression, and high-risk patients really thinking about the progression risk at about 2 to 3 years. So those are very different patient populations. So if we revisit this patient case, he had an M spike of 1.5, but his free light chain ratio was over 20 and his bone marrow plasma cells were over 20. So by the 22-20 criteria, he would have high risk smoldering myeloma. He would have 2 of these criteria. So what clinical trial data do we have in smoldering myeloma? There are 2 large randomized phase 3 studies. This was the first one done. This was done by the Spanish group of the QueerDex study, looking at lenalidomide and dex versus observation. Dex was continued for 9 cycles. And what you can see here is there's clearly a benefit in terms of time to progression, and also we're seeing an overall survival benefit. Now, though these were very impressive results, this did not lead to an immediate change in standard of care for a few reasons, really about the trial design. One is modern imaging was not used in this trial, so there was concern that those with symptomatic myeloma were included, and also the risk stratification model was something that was not easily applicable to all parts of the world. But it was important data, and you can see here in the top row, with a median follow-up of almost 11 years, we're seeing a significant benefit in terms of time to progression in the treatment arm and in terms of median overall survival. And another really important point is one of the arguments about early treatment of smoldering myeloma is that you're going to produce a more resistant relapse, meaning that when the patient does progress to myeloma, they're going to have more resistant or harder to treat disease. And so the investigators looked at the median overall survival from time of progression, and there was no statistically significant difference between the treatment arm and the observation arm. So this is really important. It's showing us that early treatment does not necessarily produce a more resistant relapse. So the follow-up study was the ECOG E3A06 trial, which was led by Dr. Lonil, the chair of our department. And this randomized 180 patients to either lenalidomide or observation until progression. And what you can see here in the phase 3 portion of the trial, the 3-year PFS favored the treatment arm 91% versus 66%. And moreover, when we used the 2018 risk stratification model retroactively, because when this trial was designed, that model was not yet in play, you can specifically see a benefit for the high-risk patients, less benefit or clear benefit with overlapping curves for the intermediate and low-risk patients. And so for this reason, and also given that the median duration of therapy on trial was 23 months, there was a relatively high, about 80% dose reduction rate. The authors concluded that there's a benefit of early treatment with lenalidomide monotherapy, but we would limit that to 2 years. And so in conclusion, for high-risk smoldering myeloma with more modern risk assessment tools, with now 2 large randomized phase 3 trials backing this decision, with modern imaging and with better therapeutics, we think it's worthwhile in terms of decreasing the risk of end organ damage and providing benefit of early, low-intensity, limited duration therapy for high-risk smoldering myeloma patients. And so how do we think about patients in our clinic? So the first thing we do is risk stratify them based off of this model. For low-risk patients, if you remember, the median time to progression was about a decade. So for these patients, it still does not make sense to do anything, and we continue to follow them similarly to how we follow an MGUS patient, with likely more frequent visits every 4 to 6 months. For intermediate smoldering, I would do the same thing with the caveat of clinical trials. We do now have some clinical trials that focus on intermediate risk patients. And then for high-risk smoldering myeloma, there's a bigger discussion here. And I do think it's completely appropriate to talk about treatment with lenalidomide for 2 years off trial. The caveat is that after 4 to 6 months, I think it's appropriate to collect stem cells. So involving a transplant center at that point in someone that you're thinking about treating if they are to be transplant eligible, or you think they might be transplant eligible at some point. And then the other conversation we have is the role of clinical trials. And then if someone is still not interested in either of those things, of course, observation is reasonable. And a few other things I want to point out. In all smoldering myeloma patients, definitive imaging of the bone is required. Skeletal survey is not sufficient. So 10% or more clonal plasma cells, I get definitive imaging with a PET-CT or other modality. Again, referral to a transplant center for those patients being treated off study. And there are curative trials in progress that you might have heard about, like the GEM-CSAR trial and the ASCENT trial, which are using much more aggressive treatment regimens, similar to what we would use in symptomatic myeloma, even including transplant. But I'll tell you, without going into detail of all that data, even in the GEM-CSAR trial, early PFS looks very similar to the ECOG PFS, meaning we're getting very impressive depth of response, which is not surprising because we're hammering the patient with treatment. but the PFS benefit is similar. So is this really worth the risk and toxicity? Okay, so if we go back to this patient, what is the next best step in management? There's actually two answers here. So I think C, lenalidomide is appropriate, but E, clinical trial is also appropriate as well, if you have the ability to refer a patient to a center. So if we return to patient case 1, this is a real patient of mine. This was prior to us having a trial, or I think he wasn't interested in having trial participation at that time. He was treated with lenalidomide, 25 milligrams on days 1 through 21 every 28 days. He started in January of 2020. We concluded in January of 2022. You can see a really impressive drop, normalization of his M spike, normalization of his free light chain ratio. I will point out the overall response rate on the ECOG study was 50%. So depth of response is actually not as important. It seems to be not as important in smoldering myeloma as it is in newly diagnosed myeloma or myeloma in general, but he did have a very nice response. And since last January, he's been on observation. And I put this up here because you do see there's a little bit of biochemical progression here on the most recent labs, but we still wouldn't do anything. Right, he has a small amount of M spike, but hopefully we've set the clock back, and we continue to observe him just like we would have before. So with that, I think a few things that we could discuss, and I'll turn over to Sara and Rosie in terms of tolerability and dose modifications, some of the supportive care, and then we wanted to mention some of the clinical trial options that are available at Emory.
Thank you. So big focus here is obviously tolerability. As Dr. Joseph mentioned, 80% of the patients on that ECOG trial did require a dose reduction. And in the phase 3 portion of that trial, half of the patients actually came off lenalidomide at some point. So the primary toxicities that we see with lenalidomide are fatigue in these patients and cytopenias. So those are our two biggest reasons for dose reductions. The third maybe being rash, but the other two being our greatest concerns. So for us, like Dr. Joseph said, we start all patients on 25 milligrams, and then our first dose reduction is usually down to 15 milligrams. There's not a big difference seen between 20 and 25, so that's why we're kind of more aggressive with that first dose reduction. And then 15 milligrams is thought to be the lowest dose we can give patients and still have cytotoxic effects of lenalidomide. As far as other things to consider too, we also consider renal dosing with these patients. A lot of our smoldering patients do not have renal dysfunction unless they have some other reason for that, where they have underlying diabetes or CKD when they come to us, but it's not myeloma driven. So we will dose reduce for renal dysfunction. And then other counseling points and supportive care I want to mention as well. So, of course, lenalidomide is regulated through an FDA REMS program because of the embryo-fetal toxicity that was experienced with thalidomide. So that's something to keep in mind. It is a limited distribution drug, so there's about 100 pharmacies in the country that are allowed to dispense this drug. So that list is available online if it's something that your clinic is not as familiar with. It's a great list. It's very helpful. And then other counseling points for the patients. We talked about the fatigue. I think that's really big for these patients to know that it's okay to speak up about that. Our job to be monitoring their cytopenias. And then for at-home, things that I really hammer home for the patients, the rash to watch for, it's pretty distinct. So we usually ask for a picture, they send it in, we know it's the lenalidomide. Diarrhea is something we see with long-term use of lenalidomide. Interestingly, it's actually due to decreased bile acid absorption. So your classic anti-diarrheals such as loperamide are not going to be effective here. Our go-to is cholesterol, so any of those bile acid sequestrants can be effective for these patients. And then the big, less common but scary side effect is the risk for thrombosis with these agents. So there are a couple of criteria within the NCCN guidelines for multiple myeloma, the SAVED and the IMPEDE scores that you can use to objectively evaluate these patients. We start all patients on aspirin, 81 milligrams. There's really not a lot of data to say that 325 milligrams is better, so we typically recommend 81 unless they have some risk factors from within those scores. So those risk factors might include immobility, obesity, a history of VTE or thrombotic event, a fracture. That applies more to our symptomatic myeloma patients, recent surgery, and all of those things we would then consider more aggressive anticoagulation. There's not a ton of data for DOACs in this population, but I will say that's our go-to. It's a lot easier than the guideline recommended enoxaparin or warfarin, so we typically do that for these patients. And then typically we will do the prophylactic dosing of those, so apixaban or rivaroxaban at a decreased dose, and then of course patients with a recent VT or AFib are going to be on full dose anticoagulation.
And then just quickly about some of the clinical trials that we offer. So currently, like Dr. Joseph mentioned, in that low-risk smoldering group, there's no clinical trials available for them just because of the time to progression and overall how well they do. It's not worth the risk. But we do that 4 to 6 month follow-up. If we start to see their numbers evolving, we might follow them a little bit more closely. And if they hit any of those criteria, 2220 criteria, and qualify for trial, offer it to them at that point. We do have a clinical trial for the intermediate risk population, so that is our iberdomide trial, plus or minus dexamethasone with a treatment of 24 months. And then for high-risk smoldering patients, we still have a clinical trial, DETER, that's looking at darzalex, daratumumab plus lenalidomide and dex. And seeing how they do with that. And I'll just echo off of Sara that these patients tolerate these really well. I often have the conversation with them that we don't want to, you're asymptomatic. I don't want to do anything that causes problems that you wouldn't otherwise have. And with a lot of these supportive cures and just dose changes or treatment changes, they do really, really well overall.
Great, thank you both. And I think the one thing I'll just add with the clinical trials is we want to talk about the trials that are available at Emory for those of you who practice in the Atlanta or Georgia area so that you know that we do have options. We also have clinical trials for MGUS as well, non-therapeutic, non-interventional trials. So if you have patients interested in those things, please refer them our way, but also to make a point that there are ongoing clinical trials around the country looking at a lot of different regimens of smoldering myeloma. Any questions about that session that I can answer now from you or anyone online? Okay, if not, I will continue on to the next case. All right, so patient case 2. So this is Miss S. She's a 72-year-old female presenting with acute onset back pain after sneezing. Plain film revealed acute compression fracture at L1. Past medical, again, hypertension, hyperlipidemia, GERD, anxiety, depression. She's a retired pastor. She's married, no children, no significant family history of blood disorders or cancer. Her medications are there. Further workup shows a creatinine of 1.8. Her calcium is almost 14. Hemoglobin is low at 9.9. Immunologic studies are sent showing 1.6 gram per deciliter paraprotein IgG kappa isotype. She has a free light chain ratio of 18 with an elevated kappa light chain of 650. Her albumin is 3.6. Her beta-2 microglobulin is 4.6, and she has a normal LDH. Further workup shows 10 to 15% clonal plasma cells. She has a normal myeloma FISH panel, so no high-risk features, and a normal female karyotype. PET scan does show several plasmacytomas in the calvarium and in the pelvis, and she has scattered small lytic lesions throughout the axial and appendicular skeleton. So this is a patient presenting with symptomatic myeloma with hypercalcemia, anemia, lytic bone disease, renal dysfunction, and we would classify her as RISS stage 2 because of her elevated beta-2 but no high-risk features. So what is the preferred induction regimen for this patient? Would it be lenalidomide and dexamethasone? Would it be daratumumab, lenalidomide and dexamethasone? RVD, len, bortezomib and dexamethasone, or daratumumab plus RVD? So let's talk a little bit about these options. So in general, this is a transplant eligible patient. I don't want to go too much into transplant ineligible today. We don't have the time. But she's 72, she has limited comorbidity, she has good functional status, a little impaired in the moment because of this new onset back pain and compression fracture, but otherwise she's in good physical shape. And so for transplant eligible patients, our ideal approach is induction therapy, followed by an upfront autologous stem cell transplant if the patient is amenable, and then maintenance therapy until progression. So when we think about this approach to newly diagnosed myeloma, why do we do these multiple steps? And the goal really is to optimize our PFS1. So when we think about myeloma, how we get to those long survivals that we're now seeing in the clinic, To get there, we have to induce nice long remissions. And the first remission is really our opportunity for the longest. The subsequent remissions tend to be shorter. So we try to optimize that first remission with induction, transplant, and maintenance therapy. And so what is the goal then of induction therapy? It's to obtain a deep response, of course, in the patients, but also by minimizing overlapping toxicities. We have a lot of new drugs in myeloma. We could keep adding and adding and adding. But the goal is not to make the patient sicker than they are at the beginning, right? We want to be very strategic about picking a regimen that's effective, but also well tolerated. And of course, taking into account the risk status and other comorbidities of the patient. And so when we talk about induction therapy, I think it's always important to start with RVD, which was our historic standard of care for newly diagnosed myeloma because it sets such a high benchmark. And this is data coming from Emory where we looked retrospectively at 1,000 patients that were treated with RVD, transplant, and risk-stratified maintenance until progression. And what you can see here is a really impressive PFS benefit in the standard risk patients of 80 months versus 42 months in the high-risk patients. And then when you look at overall survival in standard risk, it wasn't even reached with a median follow-up of almost 90 months and 86 months in our high-risk folks. And when we looked at all comers, the median survival was around 11 years. So this is really impressive. So how do we improve upon this without significant overlapping toxicity? So this is the Griffin study that many of you might have seen or read about. This is a phase 2 randomized study looking at the addition of daratumumab, which is a monoclonal anti-CD38 antibody, in addition to RVD. Patients were induced, they got transplant, 2 additional cycles of consolidation, and then maintenance therapy with dara-len or len until progression. The primary endpoint of this study was stringent complete response rate post-consolidation. This was a phase 2 study. And so when we look here, I'm showing you response rates. You can see that post-consolidation, the study met its primary endpoint. The SDR rate was 42% versus 32%, favoring the quad. And when you look at MRD negativity, you can also see, this is showing you in blue is 10 to the minus fifth and orange is 10 to the minus sixth. But overall, we're seeing higher rates or depth of response, higher rates of MRD negativity in the quad. And we're seeing this even early. So even post-consolidation, you're seeing more than a doubling of MRD negativity favoring dara-RVD. And though this was not the primary endpoint of the study, I just wanted to show you the 4-year PFS rate, because even earlier we're seeing a PFS benefit favoring dara-RVD of 87% versus 70% with a hazard ratio of 0.45. So 55% reduction in the risk of progression or death favoring dara-RVD. And just briefly, there's been a lot of work looking at quads and high risk, and if there's benefit of monoclonal anti-CD38, if there's benefit of carfilzomib versus bortezomib. And I just wanted to point out, though not a large number of patients, when you look at the high-risk patients who were included on Griffin, they had comparable depth of response and comparable early PFS to some of those more aggressive trials with dara-KRD. And so because of this, we've started moving away from dara-KRD a little bit, at least in standard risk patients certainly, and some of our less aggressive high-risk patients, and we're using more dara-RVD in all comers. So question 2, what is the preferred induction regimen for this patient? This would be dara-RVD, and this is really something at our institution we're using more and more of, and we will be publishing shortly a series of almost 350 patients who were treated with dara-RVD transplant and risk-stratified maintenance. And when we compared that historically to our RVD population, we are seeing improved PFS, OS, and depth of response. So this has really become standard of care, really for all myeloma patients, particularly standard risk patients. So returning to this patient case, this is also a real patient of mine. She was treated with dara-RVD for 4 cycles. She achieved a complete response. We followed that with consolidative autologous stem cell transplant, and then she was started on maintenance lenalidomide February of 2020. And it's been 3 years in a row she's had an MRD positive SDR, so we're continuing her on len therapy. She feels great, she has a little bit of chronic back pain, but she and her husband spent the summer on the beach and they're doing great. So I think this is a really good example of how we can get control of disease that is out of control and get the patient back to their life. So I want to then turn a little bit now back to Rosie and Sara to talk about some of the supportive care, some of the kind of more practicalities of delivering these therapies in clinic.
Thank you. Yeah, so from a supportive care perspective, this slide kind of summarizes the big buckets that we're thinking of. So as we're more aggressive with treatment, particularly including that anti-CD38, we're wiping out these patients' B cells, and so we really need to consider infection prophylaxis. We'll go into a bit more details of each of these on the next slide. BT prophylaxis, which we previously touched on again with aspirin or a DOAC, depending on your patient's risk factors, as long as they're on lenalidomide or another immunomodulatory drug. Bone modulating agents are super important for these patients. So this patient in particular, we know she has lytic lesions, but really all patients should be put on a bone modifying agent, whether that's a bisphosphonate or Xgeva denosumab. And then pain control that we consider, whether that's pain from the disease, they have extramedullary disease, they have bony disease, or if it's pain we're causing with some of our treatments, as we know that they can cause neuropathic pain. So again, this kind of goes into a little bit more of the details on the left-hand slide, kind of summarizing the NCCN guidelines, again, for thromboembolic events and VTE prophylaxis. When we think about infection, there's, again, big buckets. So viral infections are of a huge concern to us, so we put all of our patients on HSV-VZV prophylaxis. Our preferred agent is valacyclovir, just for the simplicity of once-a-day dosing. Patients should be up to date on vaccines. The big three we kind of think of are flu, pneumococcal, and then of course COVID vaccines, with those recommendations changing. The newest one to the market is RSV, so that's a conversation that's ongoing, but a lot of our patients have gotten that as well. PJP prophylaxis, specifically with the dexamethasone dosing within the regimens. My cutoff and our clinic's cutoff is dexamethasone 20 milligrams per week is kind of when we need to start considering that PJP prophylaxis. If a patient's neutropenic, we start to consider GCSF as well as antimicrobial prophylaxis, typically with levofloxacin and fluconazole. And then the last thing to consider in these patients is IVIG. So if a patient has hypogammaglobulinemia, or if they come to us with recurrent infections, we'll typically get them started on monthly IVIG. And then the last column there, the bone health. So again, all patients should be on a bone modifying agent. Zoledronic acid is our go-to for as far as bisphosphonate therapy goes. Pamidronate is another option for you. And then if they have renal dysfunction, really denosumab should be considered, and all of those are dosed monthly. One consideration as well is there's more data to support spacing out the zoledronic acid instead of monthly, doing maybe every 3, every 4 months. We have less data for the denosumab population, but it's something we can still do. Next slide, please. And then this talks about the toxicities for each of the 4 drugs that are in that quad regimen. So when I'm speaking with patients, of course, depending on their health literacy level, I'll either hit the high points, like 1 or 2 for each drug, but I think it's important for us to know what we need to monitor for each. So with bortezomib, our proteasome inhibitor, really neuropathy is the big thing that patients need to be educated on. We typically dose bortezomib in the induction setting twice a week. We know that increases the risk of neuropathy compared to the weekly dosing, but we know it can also help get us a more durable response. So that's why we're more aggressive with that dosing. This is the primary agent that does increase the risk for VZV reactivation and shingles infection, but we will keep all of our patients on valacyclovir anyway. And then there are some significant interactions here with food and medications due to its CYP3A4 metabolism, so something I talked to them about as well. We've touched on the immunomodulatory drugs already, so skipping over that. And then the daratumumab, our monoclonal antibody here, again, risk for infection. And then daratumumab does have an infusion reaction risk, so it's something I educate the patients on a lot. At Emory, we've actually transitioned to at-home monitoring rather than the package insert recommendation of monitoring for 6 hours. That's based on something that we published actually early this year, showing that the risk of reactions is less than 10%, and if it happens, it's mild. So all patients are educated on if they have a reaction, what their intervention should be, typically just Tylenol and Benadryl at home. And then there's also the steroids. So we're all familiar with steroid-induced toxicity. In this patient, she has baseline hypertension, so that's something we're thinking about. The hyperglycemia is something we monitor for. Hyperactivity, insomnia, and mood swings. I always joke with the patients that their families need to be aware of the mood swings, and they always giggle. And then PJP prophylaxis here. The other thing we can see in the Griffin trial, dexamethasone was dosed 2 days a week. We dose it just 1 day a week for ease of administration at our institution, but we can see patients kind of have those steroid crashes the next day. So if that's occurring, we will space out the dosing throughout the week, but still 40 milligrams a week is our goal.
Okay. Thanks, Sarah. So then I think other things we just wanted to touch on are factors. How do we think about transplant eligibility? How do we think about alternative regimens for induction for patients who have baseline comorbidities? And then I just wanted to talk a little bit about dosing schedule and other things that we could talk about in terms of management of AEs, or if there's any questions online. So Rosie, I'll turn it over to you.
When we think about our transplant eligible patients, it's a very multifaceted decision. It's not just based off of their age. I mean, really take into consideration their performance status. We always say if you can walk a mile a day, that's definitely a good thing. And so that's people's usually threshold. They come in with their smartwatches and saying, I did it. It's cute. And then, organ function. So they get the, BMT evaluation. If they have chronic kidney disease or acute renal failure, it's not necessarily an automatic disqualification, but definitely want to make sure that, their hearts are good, their lungs are good. We get echoes, PFTs, all those things. And then certainly want to look at social support once they get home. So those first couple of weeks out of the hospital can be really rough, and someone that doesn't have the appropriate social support and just, system to lean on, we want to set them up for success. So that's a big factor as well. And then, inductions, we really navigate to DARA RVD for our standard induction regimen, but we definitely individualize it and take into consideration other comorbidities and organ function when we're choosing that. And so if someone presents with chronic kidney disease or acute renal failure, we might lean more towards doing a DARA-VEL and adding in thalidomide, or doing DARA-VEL for a cycle or two, and as their kidney function improves, considering a renal appropriate lenalidomide in their case. And then for patients that come to us with peripheral neuropathy, we might swap out the Velcade for carfilzomib. Carfilzomib doesn't carry that peripheral neuropathy toxicity, but then again, keeping in mind the side effect profile of CAR. So making sure that they don't have any vascular issues, any cardiac issues, or if they do, making sure they're still appropriate, and we're monitoring those people very closely with like baseline echoes and just symptom monitoring and dose appropriation over time.
So as far as dosing schedule goes, for the Griffin trial, patients will typically undergo about 4 cycles of treatment before they go to transplant. Those cycles are 21 days long, and we will give daratumumab every week until transplant. So we don't kind of follow that typical regimen if you think of Dara being heavy up front and backing off. We also, as I mentioned, we will do bortezomib twice a week per the trial. We believe that gives us a deeper, more durable response. The lenalidomide, patients get it for 14 days on, 7 days off. That's how it was studied in the trial, and that's our standard practice at Emory. We believe giving them that week break is really important. And then the dexamethasone, I mentioned this as well. We stray from the trial a little bit for ease of administration, and we give them 40 milligrams when they're with us. If a patient comes to us and they already have diabetes, they already have other concerns, and we think they're not going to tolerate that, we will dose reduce that dexamethasone, but we're really trying here to be as aggressive as we can to get them into that deep, durable PFS1.
Could you talk a little bit about how we approach bortezomib dosing and how we might think about dose reducing that if someone's presenting with new onset peripheral neuropathy?
Yeah, so if they come to us with peripheral neuropathy, or we've had patients who come to us and they're a musician and they need their fingers, we will consider the weekly dosing in those patients. Our standard dose is the 1.3 milligrams per meter squared. That reducing that to weekly reduces the incidence of neuropathy. The other thing we can do is go to 1 milligram per meter squared. That also will decrease the incidence of neuropathy. I will say I see us be a little more aggressive in this induction unless the patient has, those lifestyle things that we really need to take into consideration. Unfortunately, there's nothing we can do to prevent the neuropathy from a medication perspective. It's really dose adjusting. But once they have it, we do have some treatment options. I also do tell patients, unfortunately, I don't see a lot of patients fully recover from the neuropathy, but once we stop the bortezomib, they do tend to get a little bit of the sensations back, and it can decrease in severity, but I don't really see them fully recover, which is important when we're talking about the lifestyle modifications as well.
Great, thank you both. Any questions online or in the room? And if not, I'll move on to our final case. Okay. All right, so patient case 3. So very briefly, I'll go through this, and then I really want to spend the rest of the time talking about some of the novel therapeutics in multiple myeloma in the relapse space. So Mr. B is a 64-year-old gentleman. He has a history of relapse refractory myeloma who was diagnosed in 2015. So he's 8 years in. And he came in to talk about what do we do now. He's progressing on his current regimen. I'm not going to go through everything here, but you can see that he's heavily pretreated. He's had 2 autologous stem cell transplants. He's penta-refractory, and he's currently on Darapam with a rising amount of free kappa light chain in his serum. So as many of you know, we have a lot of options now in myeloma, and this is growing very rapidly. We had 2 approvals just recently for 2 bispecifics, talquetamab, which is an anti-GPCR5D CD3 bispecific T-cell engager, as well as elranatamab, or Elrexfio, which is another BCMA CD3 bispecific, just like teclistamab. And we have 2 CAR T-cell therapies approved for myeloma, cilta-cel and ida-cel. And so I wanted to spend the remainder of the time talking a little bit about 4+ lines in myeloma. How do we approach these patients, and what is some of the data on these bispecifics? So I think as we move forward, this is going to become more and more common in the community, and hopefully we can partner more and more with the community to bring these therapies to our patients, particularly those who don't live close to an academic center. So let me turn it over to Dr. Scott. She wants to talk through a few of these slides.
Yeah, thank you. So as Dr. Joseph mentioned, there's a lot of excitement in myeloma, subjectively to me the most exciting disease right now with all the therapeutic changes we're seeing in all the trials. So as she said, teclistamab was approved last October. It was our first-in-class BCMA CD3 bispecific T-cell engager. This is a summary of the Majestic-1 trial that achieved approval for this drug, and here displayed is the overall response rate. So in this trial, there were about 157 patients, and we saw an overall response rate of 63%. Of this overall response rate, you can see the vast majority achieved a VGPR or better. So really impressive, especially in this late-line population where we previously honestly didn't even really have treatment options for them outside of CAR T if they were eligible or if they had the time to wait for CAR T. Interestingly as well, of these patients that were accessible for MRD, about a quarter of them did achieve MRD negativity. So these responses were quick. We did see durable responses in a good amount of patients, so this was really exciting. This is for elranatamab. So this is our second BCMA-directed bispecific T-cell engaging antibody. So this one was approved just less than a month ago. The world is changing very quickly. So here summarized is the response rates for elranatamab from the MagnetisM-3 trial that was published a couple of weeks ago. Really, the results are super similar to teclistamab. So clinically, we're kind of having a hard time distinguishing between the two. The baseline characteristics of this trial were very similar to teclistamab with a couple of exceptions. There were some more stage 2 patients in this trial compared to the Majestic-1 trial, but really it's gonna be a while until we kind of have a difference between these two. Interestingly, they also reported outcomes based on some disease characteristics, and that's summarized in the figure on the right. So patients with extramedullary disease, more advanced disease, so R-ISS stage 3, and then penta-refractory disease did have decreased rates of response compared to their cohort. But you can see there's still pretty impressive responses ranging from 25 to 46%. So really we're seeing impressive responses in this really late stage population. And then next slide, please. And then this is the summary from Monumental-1. That was the trial that assessed talquetamab. So this is another first-in-class agent targeting a new target, which is GPRC5D. Lots big acronym there that I can never remember. So this is present on the plasma cells. This also has impressive overall response rate. And one thing I want to point out is in that patients that had received previous T-cell redirecting therapy, whether that was a bispecific antibody or CAR T-cell, they still had an impressive overall response rate of 64.7%. So this is kind of helping us in our sequencing right now until we have more data. One thing to consider with this therapy is this target is less specific than BCMA. It's also seen on skin cells and in the GI tract, so we're seeing some interesting toxicities with this drug. So I think that's also going to help us see the utility of it as we move forward. And then quickly, I wanted to touch on as well CAR T cells. These have been around a little bit longer. Our first one came to market in 2021. That was a Abecma or ide-cel, and then Carvykti was approved in 2022, or cilta-cel. Here is the overall response rate for these two drugs. So this is kind of where we can tease out, if we had the opportunity to select between the two products, what we would kind of look at. So the overall response rate for ide-cel in the KarMMa-1 trial was 73%, and then the overall response rate for cilta-cel in the CARTITUDE trial was 97%, so like absolutely unheard of in this population. But then really this shows what we would prefer if we could based on the PFS of both of these agents. So the PFS of ide-cel is about 12 months. We recently had new data presented for cilta-cel at ASCO this year, and their PFS at a median follow-up of 34 months was 34.9 months. So again, unprecedented, really exciting. And I think if we had a preference, it really would be cilta-cel. But of course, these agents have not been directly compared, and I don't know that we'll ever see that data. So making our best educated guess based on this PFS would be that.
I think another point I'll just make about cilta-cel is that CARTITUDE-4 was recently reported out, which compared cilta-cel to standard of care in an earlier line, so 1 to 3 prior lines instead of 4+. And we did see a PFS benefit in the cilta-cel arm. And the reason I point that out is really just for the sake of, I do think, because patients ask all the time, that we will have earlier access to CAR T very soon. I don't necessarily know if that's going to be our go-to choice for first relapse or second relapse, because those curves tend to plateau, and we have very effective therapies otherwise in the clinics. But at least we have earlier access, because some of the challenges of CAR T is you have a 4+ relapsing myeloma patient, and we have a hard time bridging them sometimes to wait for the manufacturing of those CAR T cells. So just something to keep in mind.
And then the last thing to touch on is with these new T-cell engaging therapies, we do have a unique toxicity profile with CRS and ICANS, or the neurotoxicity. So this is something I think, as hematology groups, we've become familiar with a little bit more. We've had CAR T for a while in the lymphoma space, but it's something we really need to consider. So CRS requires fever, but other symptoms are going to be hypotension, hypoxia, and then multi-organ failure in severe cases. I've summarized here the incidence for you. Overall, CAR T has more CRS and more severe cases of CRS. So with bispecific antibodies, those grade 3 or higher are 1 to 2%, where with CAR T, we can see it a lot more. And then management of CRS and neurotoxicity is something that must be considered as well. So right now, our bispecific antibody package inserts do carry a statement that say patients should be hospitalized, and that's for monitoring for this CRS. We are kind of trying to see if there's ways to mitigate that and get patients outpatient to prevent that hospitalization, but right now that's where we stand. Typically with CRS, our first treatment is going to be tocilizumab, our anti-IL-6 monoclonal antibody to mitigate. That's kind of the primary cytokine involved in CRS. We will also use steroids for more severe cases. Considerations there used to be we were worried that the use of steroids is killing off those T cells when we administer CAR T, but we've seen there's some more recent data suggesting that may be debunked. With bispecific antibodies, we're less worried about that. We're redosing them, give them the steroids, it's going to be okay. And then, of course, supportive management, supportive care. When it comes to ICANS, this is where we see a greater difference between CRS and bispecific antibodies. ICANS is occurring more often with CAR T, up to 21% of patients. With bispecific antibodies, it's reported in up to 15% of patients, but it's important to note that we're not seeing ICANS without CRS. So if they have it, they have both. With CAR T, they can have ICANS on their own. Management for here includes a lot of neurologic assessments. The other consideration with ICANS is this can happen late. So we are still assessing for this in clinic. We do give all patients on CAR T seizure prophylaxis. That hasn't been established for bispecific antibodies yet. Again, the steroids. And then tocilizumab has less effect here because it doesn't cross the blood-brain barrier.
So I think with that, thank you so much, Sarah. We're going to have to pause because we're run out of time. But I think in general, we just wanted to bring up these therapies. We're going to see more and more of them, hopefully in the community soon. Certainly we're using more of them at Emory. And there's ongoing clinical trials, not only as monotherapies, but in conjunction with each other. So the redirect study looked at teclistamab with talquetamab and showed had really impressive results in a refractory population, and in combination with other standard of care anti-myeloma agents. So a lot more to come in this space. With that, I'll just say if there are any questions in the room or online that we're happy to address.
No questions online, any in the
Okay.
room?
All right.
Thank you
Well,
so
with that, thank you so much for your time.
Thank you.